This is a session with Dr. Sriram Iyer, who is a cardiologist in Manhattan, and his daughter, who's trying to turn the screen away from her face at this point. Um, and the idea behind the talk that you're going to see tonight is from the cardiology perspective, but really from the medical in general perspective. Dr. Iyer did one of these last week for us, and it was excellent. So I'm thrilled to have him back. But before we get started with his talk for you guys, I want each of you to take a turn, introduce yourselves, including where you go to school and what grade you're in. So, Anoki, why don't you go ahead and start?
Okay, my name is Anoki Soklecha, and I'm a senior, and I go to the Harker School in San Jose, California.
All right, Amanda?
I'm Amanda Ramage. I go to MICDS in St. Louis, Missouri, and I'm a senior.
Okay, thank you. Dana?
My name is Dana. I'm a senior this year, and I go to Jakarta International School in Indonesia.
Excellent. Thanks for being here. That's great. Elizabeth, your turn.
Hi, I'm Elizabeth. I go to the Catlin Gable School in Portland, Oregon, and I'm a senior.
Terrific. And that leaves you, Reed. You're up.
I'm Reed. I go to Greens Farms Academy in Westport, Connecticut, and I am a sophomore.
Okay. I am, just so everybody's on the same page, Anoki knows who I am because I'm her teacher, but my name is Derek Hershka. I teach, obviously, MPS for GOA, and I work at the Brunswick School, which is in Greenwich, Connecticut, which is just down the road from where Reed is at the moment. And I want to turn it over to Dr. Iyer. It's all yours.
Good evening, guys. My name is Sriram Iyer. I'm a cardiologist, and I practice in Manhattan, New York. And I'm here with our daughter Anjali, who's a sophomore at the Dalton School here. So it's a pleasure to be involved in this program, and we did one a week ago. So you have asked a couple of questions regarding my background and what do I do and how did I get here. So I went to medical school after completing 2 years of pre-medical training in the city of Mumbai. And after finishing about 4.5 years of medical school, I got a degree called MBBS, Bachelor of Medicine and Bachelor of Surgery, following which we had to do a 1 year of what we call rotating internship. At that point, you are qualified to call yourself a doctor. Very green, very inexperienced, but that sets you on the road to hopefully bigger and better things to come, which indeed it did for me. I then went on to specialize in general internal medicine, which was another 3 years. And during that time, you go through certain positions called house physician jobs. And ultimately, this is a British system, so we call it a registrar. There's a very big public hospital, more than 1,000 beds. And then after training for 3 years, I went ahead and decided to specialize in cardiology. And took me another 3 years to specialize in cardiology, and that gave me a doctorate degree in cardiology. And at that point, I came to the United States more than 25 years ago. And one of my stops was in Washington University School of Medicine in St. Louis. Went to the Jewish Barnes Hospital.
And my mom works there.
She does.
Yeah.
That was many, many years ago. Today, what I do is a branch of cardiology called interventional cardiology, whereby I have the training and the expertise to treat blockages inside blood vessels. And those blockages may be either in arteries supplying blood to the heart, those are called the coronary arteries, or it could be in the arteries supplying blood to the brain. There are two such big arteries on either side of the neck. They call the carotid arteries. Or it could be in the arteries, say, supplying blood to the legs, and that would be in the realm of what we call PAD, or peripheral arterial disease. Depending upon which end organ is affected, which means that where the blood supply is compromised, the patient presents with a different set of symptoms. So for instance, if there are severe blockages in the artery supplying blood to the heart muscle, then the patient will present with what we call exertional chest pain or angina. So the typical way the patient will describe the symptom is, the other day I was walking down Manhattan, and after walking 2 blocks, I felt this very strange sensation of as if somebody was squeezing, a pressure-like sensation. I thought maybe I'd pulled a muscle, but then as I kept walking, the pain started to go down the left arm. My jaw started to hurt a little bit, started feeling a little uneasy. These are all telephonic diagnostic terms for me. If somebody reports something like this, unless proved otherwise, this is angina and the patient requires or deserves further investigation and then, of course, treatment. So that's what happens if the blood supply to the heart is affected. What happens if the carotid artery supplying blood to the brain gets affected? So in the neck, there is a big artery. Can you just bring up the first PowerPoint slide?
Indeed, I can.
Yeah. So Anjali is going to just bring up a slide and I'll show you very quickly.
So I'm about to share the screen with everyone. Don't be alarmed if your screen changes.
Let's go to the first one.
This one?
No, very first.
Can everyone see the screen?
Yeah, extracranial.
Yeah.
All right, awesome.
So what you're looking at here is this, all these are bones. These are the spine in your neck, which we call the cervical spine. This is the outline of the jaw. This black structure here is the tube that we call the carotid artery. This is the right carotid artery, and about halfway up the neck, you can see that the carotid artery splits like the limbs of the letter Y. One of these tubes, which has got all these branches, we call the external carotid artery because it supplies blood to all the structures outside the skull, the skin, the face, the jaw. The other tube, the one here, called the internal carotid artery because it actually goes through the skull. Skull base is right here, and then it supplies the brain. The brain is situated right on top of the screen. And you can see it just after it splits off, there is this very nasty looking narrowing. This is what we call a blockage or a stenosis. And because of this stenosis, the blood supply through this carotid artery gets affected. So the right carotid artery, right internal carotid artery, supplies the right half of your brain, which controls the left side of your body. The left internal carotid artery supplies the left half of the brain, which controls the right side of the body. The speech center in almost all of us, especially if you are right-handed, is located in the left half of the brain. And in most left-handed people, the speech center is also located in the left half of the brain. So sometimes people or patients with blockages in the left internal carotid artery can manifest with speech disturbance. So just like the patient with coronary artery disease presented with chest pain going down the left arm, the patient with carotid artery disease may come to me and say, the other day I was talking to my son, I could not articulate, I could not speak. And it just went away in a couple of seconds and everything became normal. So a brief transient disturbance of neurological function like this is what we call a TIA, a transient ischemic attack. What's happening here is momentarily the speech to the left half of the brain, which carries the speech center, was affected. Because the speech center was affected, the patient's speech output was affected. And because this was temporary or transient, the entire neurological problem reverted back to normal. But it is a signal to us that perhaps there is something wrong in the carotid artery and that requires further treatment and testing. Finally, when we look at the legs, we talked about peripheral arterial disease. So a patient with PAD will present in the following manner. We'll say, well, I was an athlete all my life. I could run, I could jump, I could walk, no problem. But for the last 6 months, when I walk more than 2 or 3 blocks, I get this peculiar cramping in my right calf. I have to stop for about 3 or 4 minutes and the cramping goes away. So this symptom of cramping, which comes up with activity or exertion and goes away with rest, is what we call claudication. Claudication is from the Greek word which means to limp. So these are just some manifestations as you look through all of these medical problem solving exercises that you all go through. You may come across, if you do have a chance, I don't know if Derek is planning any more of these. If he does, then he may choose to give you an arterial disease problem, and if it affects one of these organs, that's how you start thinking about it. So I could continue and show you what we did for this patient real quick, but what I'm going to do right now is I'm going to take a few minutes off and I'm going to ask if there are any questions, and then what I will prefer to do today is to quickly review with you the case that I think all of you reviewed a few weeks ago, and that is the 46-year-old Samoan male who had a problem of palpitations and shortness of breath. And I'll show you from a cardiologist's perspective, how do I handle that particular problem, how do I make a diagnosis, and what kind of treatment will we give this individual. So any questions so far? Otherwise, I'll review this case with you.
I just had one. What made you specialize in cardiology?
Nothing very specific right now. I can, of course, give you a dozen reasons, but at that time, I think the most compelling reason for me was it is a very dynamic field. You know, there's a lot of things going on, both in terms of the complexity of the heart anatomically, and as you will see by discussing this case, although it's a very small organ situated predominantly in the left chest, it's a very complicated organ compared to a simple piece of intestine, or of course it's not as complicated as the brain. But be that as it may, there are a number of things that you can do to treat conditions of the heart. And the combination of complexity of structure, challenges in diagnosis and treatment, and of course the excitement of something very dynamic, I think that's what probably compelled me all those many years ago to choose cardiology as a specialty.
Go ahead.
Have you done any surgeries on the femoral artery in the leg?
Yes, I have.
And isn't that a really invasive procedure?
So I think the answer that I gave you was partly correct. I do not do surgery. I do angioplasty, which is a less invasive form of treating blockage. So for instance, the artery that you talked about, the femoral artery, is the artery that connects the thigh to the knee. So the groin to the knee, there is that spanning the length of the thigh is an artery called the superficial femoral artery. That's what we call the SFA. So if there are blockages there, that's when the patient will present typically with claudication symptoms involving the right calf or the left calf, depending upon if the right or left SFA is involved. So if there is a blockage, and especially if the artery is completely closed, then sometimes we are unable to treat it with minimally invasive techniques or non-surgical techniques like angioplasty, in which case I would refer the patient to my surgical colleague who will do or will construct a bypass. So they will reroute the blood. Instead of it going through the original channel, they will take a piece of plastic tubing and hook up one end of that plastic tubing above the blockage, sometime somewhere, let's say, high up in the groin area, and then bring that tube all the way down and connect it to the artery beyond the blockage, either above the knee or below the knee, so that the blood, instead of going through the original channel, which is either completely blocked or has a severe blockage, now goes through this alternate pathway, what we call a bypass. So that is what is done by a surgeon. What I try to do is to open up this blockage using a system of wires and tubes and balloons and some fun scaffolding material called stents to keep the artery that I put a balloon and opened up the blockage to keep it open. That's what I do as an interventional cardiologist and a vascular physician. Yes, so this particular example was in the femoral artery, and so yes, I am trained to perform angioplasty in the femoral artery as well.
I'm curious from an anatomical perspective. If you're going to do angioplasty, let's say you're going to do a coronary angioplasty or even a carotid angioplasty, don't you normally go in through the femoral artery, or where do you enter with a minimally invasive angioplasty? Where do you normally enter the cardiovascular system?
So for the coronary artery, you have a choice. You can either go from the femoral artery in the groin, or you can go from the radial artery at the wrist. In fact, there is more and more, that is becoming more and more popular. For the legs, depending upon which side is involved. So if the right leg is involved, I'll usually come from the left femoral artery, go north, and at about the level of the umbilicus or the navel, the aorta, which is that big tube in the belly, in the center of the abdomen, it splits into two. One goes to the right leg and the other one goes to the left leg. And I pick it up at the level of the groin or the femoral artery, go north, and then turn around and come into the other side. So that's what is called a crossover approach. Or I can come from either the brachial artery near the elbow or also from the radial artery. So all depends upon where the problem is. Sometimes we use some very exotic approaches, like we come from the foot. There's a small artery just behind the bones near the ankle, and we can make a small incision there and we can come up from there. And our group was one of the first to describe this all those many years ago, these new approaches. So it all depends where the pathology is, where you want to go. But in general, for the carotid and the coronary, we come from the groin. For the leg, depending upon where it is, we have alternative approaches.
Thank you. I find that fascinating and so cool.
Yeah.
But thanks.
So let's take a quick look at this. What time do we have?
It is currently 10:25
Okay,
p.m.
so we have about 20-25 minutes. We'll try and go through this. So when I'm faced with a clinical summary like this, not yet. So let's take a look. So we have a 46-year-old male, a Samoan male, which immediately tells me, okay, he's outside the United States. So he's from probably a different socioeconomic strata of society. Perhaps he grew up in a different socioeconomic, and I know all this very well because Mumbai and India, you see a very wide variety of patients. Most of them are quite poor, so they are exposed to diseases that you may or may not encounter, or things that you see because of overcrowding, not good hygiene, poor nutrition, infections. All those things start coming to my mind as I look at it. So he's 46 and he presents because his heart is beating too fast. So what he's trying to tell us is that he has a symptom called palpitation. So even though your heart beats about on average 70 times a minute, you do not feel it. And thank God for that, because you can imagine if you feel every heartbeat, you go completely nuts. But that's the protection that nature has provided us with. But if the heart races too fast, or the rhythm which normally is regular starts to become irregular, then the patient starts to appreciate his or her own heartbeat, and that is what is referred to as palpitations. So we have a 46-year-old man with palpitations, and then I say, okay, let me take a look at why. There are many reasons why there could be palpitations. So the first thing that I'll think of as a cardiologist is this palpitations occurring in the context of an anatomically normal heart, or is it occurring within the context of an anatomically abnormal heart? This is the first thing that I'm thinking of. I mean, I'm thinking of many things. But why is that important? Because a palpitation that occurs within the context of an anatomically normal heart, and we'll talk about that in a second, typically we call that a primary arrhythmia. Something is wrong with the rhythm of the heart. So you can think of the heart as like a house, just like the house has got walls, the door, the hinges, bricks and mortar. Those are all the things that are the equivalent in the heart is the wall of the heart, the valves of the heart, the partitions in the heart, similar to a house. You can also think in terms of the plumbing that brings water to your home. The arteries that supply blood to the heart muscle are like the plumbing. If something gets wrong in the plumbing, you don't get water. Something gets wrong in the plumbing, the heart doesn't get enough blood, patient presents with angina. And there is a particular electrical system, a system of fibers that takes the impulse, and we'll talk about that if time permits, that activates the entire heart.
The conduction system.
That's what's called the conduction system of the heart. It's an extraordinary organ because the muscle of the heart has the ability to respond to this electrical stimulation by mechanical contraction. So that's what is such a fascinating thing. Normally, if you have an electrical stimulus, well, it's an electrical stimulus. But here, the muscle of the heart, what we call the cardiac myocyte, it's such a specialized muscle organ that it converts this electrical system, electrical impulse, and starts to contract. So now you can imagine if the electrical impulse is coming regularly, the heart muscle is going to go regularly, like I'm showing you with my hand. If something goes awry here, then either it starts doing that or it starts to beat irregularly, and all that is felt as palpitations. So if that occurs within the context of a normal heart, primary arrhythmia. If it occurs in the context of an abnormal heart, we need to sort out what is the arrhythmia and what is the underlying cardiac abnormality. So let's see if we get some clues from the history, and that's what I start thinking as a cardiologist. So even before I approach the exam, I need to make up my mind, what are my top 3 diagnoses? We may be wrong, but that's how it's like a puzzle. You start to analyze everything that the patient tells you. Some of it is completely disconnected, or some of it, if you're not familiar with the problem, you may not recognize the importance of some of the stuff that he or she is telling you. Let's see what he tells you. So these palpitations have been associated with generalized fatigue, not unusual. Why? Because as the heart starts to pump faster, it's like think of it of you almost always continuously running a race. If I make you run around 3 laps, you are going to be fatigued. That's because your heart is working extra, you are working extra, your muscles are working extra. Think about the heart is continuously pumping even when you're not physically exerting. That's what's contributing to the fatigue. Mild shortness of breath. Again, when you run, you do get short of breath. When the heart starts to pump so fast, there are some pressure changes that occur within the chambers that translate into some congestion in the lungs that can cause shortness of breath. Lightheadedness, but not syncope. Extremely important symptom for me to know, because syncope simply means the inability of the patient to maintain the posture, let's say in a standing position, and all of a sudden the patient loses consciousness and either has a frank fall to the ground or he feels that he is going to fall and pass out. And that's the distinction between syncope and near syncope. Syncope in the context of an arrhythmia simply means that the heart is pumping or beating so fast that effective amount of blood coming out of the heart is not adequate to supply the brain with enough blood. And when that happens, the patient doesn't get enough blood, he becomes lightheaded, and the extreme manifestation of that is syncope. Conversely, there could be some valves within the heart that are not completely opening and closing. And if they are not opening very well and they're just opening a little bit, not enough blood is exiting the heart. So I'm already starting to think, okay, here is somebody who's got palpitations, he's 46, he's coming from out of this country. He could either be having an arrhythmia that is causing lightheadedness, or it is probably occurring in the context of an abnormality in the heart. Now, he denies a history of cardiac disease. Now, let's see what happens in the past medical history. Past medical history, just to summarize, he gives you a very important piece of information. He says, growing up as a child, he remembers having several bouts of infection accompanied by fever around the time he was 8-10 years old, and he remembers that his joints were sore. When you have soreness of the joints, repeated episodes, fever at the age of 8 or 10 years old, and 30 years later when you have something to do with the heart, ex-US patient, I'm thinking, are we dealing with rheumatic fever? And why is that? Because this is the typical presentation. Growing up in India, I probably have seen a whole lot of rheumatic fever. This is one of the commonest things that you see there, but the profile is changing. 25 years later, the profile has changed. However, so what happens? So typically in rheumatic fever, the patient has an antecedent or a previous sore throat caused by streptococcal infection. It's a particular type of streptococcus called alpha-hemolytic streptococcus, and the immunological reaction to that particular infection is such that the body mounts a pretty vigorous immunological response to get rid of the streptococcus, but that immunological response, unfortunately, also tends to attack some other tissues of the body. One of them could be the joints, but tragically, it could also involve the heart. Whereas the joints completely recover, means there is no lasting damage to the joints, the heart is not so lucky. So we usually call it rheumatic fever licks the joint and bites the heart. That's typically how we think about it. So he's got fever, sore throat, multiple episodes. I'm thinking in terms, bring up the Jones criteria, please. In terms of fever, rheumatic fever. So I'm going to jump a little bit only because of lack of time. And you all have seen the report. Let's go down. Okay. So,
does everyone see the Jones criteria to diagnose rheumatic fever?
Yeah.
Yep.
Okay. So there is something called Jones criteria to diagnose rheumatic fever, and these criteria are divided into major criteria and minor. The major criteria are what we call carditis, and I'll talk about that in a second. Polyarthritis, that's what this gentleman presented with. Multiple joint pains. Chorea. Chorea is if you see chorea in this setting, it's almost diagnostic of rheumatic fever. That is involuntary movements that you feel as if the patient is flinging their arms and legs about. That is what we call chorea or Sydenham's chorea. Erythema nodosum, and I'll show you an example, and subcutaneous nodules. So when you have either two major or one major and two minor, notice that arthralgia is joint pain arthritis is joint inflammation. So you have fever. So if you have one of these criteria here, fever, joint pain, prior rheumatic fever, an elevated sedimentation rate, these are all blood tests, or a prolonged PR interval on the EKG, and I'll show you an example with some of these blood tests. These blood tests simply tell you that the patient has had a prior streptococcal infection or a positive throat culture. That's what you need to make a diagnosis of rheumatic fever. So I'm looking for this in the history. I'm seeing, okay, as a child. Now remember, 30 years later, all you can go by, he does not have acute rheumatic fever. These criteria would be relevant if he had come to you at the age of 8 or 6 or 9 or 10. This is to diagnose acute rheumatic fever. What you're seeing in Mr. Saipia is the effects of rheumatic fever 30 years removed. So all you're seeing now are the sequelae of the cardiac manifestation, perhaps, of rheumatic fever. Okay? So let's not be confused. What I'm showing you on the screen is if a child comes to you with multiple joint pains, fever, sore throat, you put a stethoscope and you find the heart racing away at 120 beats per minute, you must start thinking, am I dealing with rheumatic fever? Mr. Saipia has got none of this, but he's got perhaps the delayed manifestations or cardiac manifestations of rheumatic fever. So in the acute, at the age of 10, when we call carditis, remember there are 3 layers of the heart. The innermost layer we call the endocardium. That's a very fine layer that lines the chambers of the heart. The muscular layer we call myocardium, and covering the myocardium is a thin sheet, what we call the pericardium. And all 3 layers can be affected in rheumatic fever, so you can have rheumatic carditis, myocarditis, and pericarditis. Pericarditis usually resolves, myocarditis usually resolves, but when it affects the endothelium, that's when the valves get affected. When the valves get affected at the age of 10 or 12, as the healing process is completed, it leaves behind a very scarred, abnormal valve, which then can explain some of the symptoms that Mr. Saipia is manifesting with. Okay? The one other thing that I note here is he's a Jehovah's Witness. We talked about last time what the implications are. So, when you examine Mr. Saipia, and when I'm thinking of rheumatic fever, although I don't think that he will have rheumatic fever now, an abnormal valve, the abnormality caused by rheumatic fever from 30 years ago, is prone to infection. Why is that? Because a normal valve is very smooth. It's like tissue paper. Nothing sticks to it. Blood RBCs, platelets, etc. simply slide off the top of the valve. But when you have an abnormal deformed valve, you can accumulate small platelet clumps on top of it, and that forms a small blood clot, which can then start to become the nidus for lodging bacteria, which then infect the valve in a process called infective endocarditis. So that's something that I keep in mind when he comes to me and I look for fever and other telltale signs of infective endocarditis. So let's take a look. So you remember we talked about subcutaneous nodules. This is a nodule, subcutaneous because it is sub or underneath cutaneous skin, underneath the skin. Here is the elbow and here is the back of the arm. This is the triceps muscle is right here. The shoulder is here. Here is something called erythema marginatum. You can see the margins are raised and red. This is not painful. If you see some things like this, I know that in the history and the exam, they were looking for something called Roth spots. So the next 3 slides, I'm going to show you things that are indicative of infective endocarditis that we spoke about. So when I look in the patient's eye with an instrument called the fundoscope, I can see the retina. All these blood vessels that you see are normal, but these blotches of red that you see with the pale center, this is not normal. This is a hemorrhage. This is a hemorrhage in the eye surrounding a pale white center, and this is what we call a Roth spot. Here is a hemorrhage, no pale center, but this is a classic Roth spot. And when you see that within the context of somebody having rheumatic fever, there goes a very high suspicion that this patient has probably got infective endocarditis. Another indication of infective endocarditis is this hemorrhage underneath the nail bed, what we call a splinter hemorrhage. It looks typically like as if a splinter has lodged inside or just underneath this patient's nail bed. One other thing is when you look at the patient's palm or soles of the feet, you see these small reddish blotches. These are what we call Janeway lesions. So we look for all of this in the exam, and that's what you have when you look. You either say they are present or they are absent. You don't say that in every case, but in a case like this, we look for and say signs of infective endocarditis are not seen. Okay, let's take a look at a couple of other things that you tell me. Now let's just focus on the cardiac exam. In the cardiac exam, you tell me that the pulse is 150 beats per minute and it's irregularly irregular. Can you bring up the picture? Yeah. Sure. So 150 is clearly way too high. Remember, we talked about it being about 70 beats per minute. So can all of you see? Okay, what's that? Can you see this? Okay. I want to see this.
I know.
Can you see this diagram that I put up here?
Yes.
Okay. So here is a graphic representation of the four chambers of the heart. Here is the right atrium, the left atrium. The right atrium opens via the tricuspid valve into the right ventricle. The left atrium opens via the mitral valve into the left ventricle. Sitting on the top of the right atrium is this small battery which we call the SA node or the sinoatrial node, and this is what generates the impulse which then travels through the electrical conduction system and activates the rest of the heart. So there are small fine fibers that connect from here, go down here. There's a little junction box here where the impulse spends a few milliseconds and then activates the heart. And when the impulse comes down to this chamber, the heart will squeeze. Normally, this node will throw an impulse like this. And what you're seeing here is the contraction of the atria. And that's what generates the P wave on the electrocardiogram. Remember, I told you the impulse spends a little time in this junction box here. That's why you have this flat line, what we call the PR interval. The PR interval is the time we estimate on the cardiogram from the start of the P wave to the beginning of the R wave. This QRS, so there's a Q wave which goes down, an R wave which goes on top, and the S wave which goes down here. This complex is a result of contraction of the ventricle. And when the ventricle relaxes, you will get this T wave. So P, QRS, T, P, QRS, T, and this occurs in a very regular fashion, 70 times a minute. In atrial fibrillation, the impulse no longer starts regularly from here, but somewhere in the atria, the impulse starts and it looks like this. It's very irregular, and the whole rhythm is irregularly irregular. Okay, so if you take any 1 minute, you may get 70 beats, the next minute you may get 90, the third minute you can get 50. That's the irregularity that you use. And the irregularity is not that in every minute interval or every 30 seconds, it doesn't repeat itself. In 1 minute, it could be 90 beats. The next minute, it could be 120. In the third minute, it could be 150. So not only is it irregular, but it's irregularly irregular. That's what, when I put my hand on Mr. Sapier's wrist and feel for his pulse, I make a note of that. And not only is the rate fast, it is irregularly irregular. And when I look at the EKG, I know I'm jumping here. This is not how I normally would do it, but in the interest of time, I just want to hit the high points. Because it's not originating here, I will see a couple of things on the EKG. The rate is quick, 150 beats per minute, and preceding every QRS, there is no P wave. When I see that kind of rhythm, that it's fast, irregular, and no P wave, the diagnosis is atrial fibrillation. So I know the patient has got atrial fibrillation. He's got rheumatic fever. He does not have any signs of endocarditis. Then you tell me that the PMI, or the point of maximum impulse, show me that first, is in the 6th left intercostal space in the anterior axillary line. Okay, so yeah. So if you look at this, this is the cardiac silhouette. These are the two lungs. Here is the apex. Normally this spot should be in the 5th left intercostal space between the space bordered by the 5th rib. And this point here, if I draw a line up, should be the middle of the clavicle. Now you can imagine if this heart becomes enlarged, the apex is going to be displaced out and down. So when that happens, I know that the heart is enlarged. I don't need a chest x-ray. I don't need anything else, just by my clinical exam. So what you are telling me is that this impulse is now down in the 6th space and in the anterior axillary line. That's what tells me the heart is enlarged. So when I put my stethoscope, I put my stethoscope at the apex, I put it at the base, and I put it here around the this is called the tricuspid area. And what I'm looking for is what you have all been taught, right? Lub, dub, lub, dub. The lub is the first heart sound. We graphically illustrate that as S1. The dub is the second heart sound, graphically illustrated as S2. In the first heart sound, what happens is the mitral valve and the tricuspid valve close. That's what generates the first heart sound. The second heart sound is generated because the aortic valve and the pulmonic valve will close. This interval between the first heart sound and the second heart sound is called systole. The interval between the second heart sound and the first heart sound here is called diastole. So normally you shouldn't hear anything else but a lub-dub, 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 lub-dub. But in Mr. Show me the next one. But in Mr. Sapier's case, what you're telling me is the first heart sound is diminished. And the reason why it is diminished is because of atrial fibrillation. The mechanisms are unimportant. The second heart sound is widely split. I won't go into the mechanism of that. And you're telling me that there is a grade 4/6 holosystolic murmur. What does that mean? See what I've shown you here? Holosystolic means it occupies the whole of systole. The entire systole is occupied by a murmur. So what it will sound like is sht, 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 sht. That sh is the murmur. The t, t is, it ends with that second heart sound. But it's occupying all of systole. Now I've shown you what is called as a 3/6 murmur. But in your case report, you're calling it a 4/6 murmur. What's the difference? In a 3/6 murmur, when I put my hand on the patient's chest, I don't feel a rumble. In a 4/6 murmur, when I put a hand over the patient's chest, coincident with the murmur which I'm hearing in my stethoscope, I'll feel something swirling around below my hand. That is what is called a thrill. And if you look 3 or 4 spaces up, you'll see a thrill is palpable. That's what makes the murmur a 4/6 murmur. When I look at the lungs, his lungs are clear, his abdomen is soft. I don't see any signs of an enlarged liver, for instance. Why am I looking for that? Because if the patient is in heart failure, the liver will get enlarged, and there are other signs that happen. So what is my diagnosis clinically? So clinically what I'm seeing is somebody who has got a suggestion of rheumatic heart fever, now possibly has got rheumatic heart disease, has got an enlarged heart on clinical exam, is in atrial fibrillation, there's a hollow systolic murmur, and that combination tells me that this patient has what we call leakage of the mitral valve. That's what's causing that hollow systolic murmur. So the way I would present my diagnosis here would say 46-year-old male with known rheumatic fever presents with rheumatic heart disease in atrial fibrillation with clinical features consistent with mitral regurgitation, no signs of heart failure, no signs of active rheumatic carditis, and no signs of infective endocarditis for further investigation. And I will do an EKG, an echo, all with an idea to know what do I need to do to treat him. And the treatment will be medications to slow down his heart rate, medications perhaps to try and see if we can put this rhythm back to normal. He may require blood thinners because atrial fibrillation predisposes you to the formation of blood clots, which can then be discharged and go into the brain and cause a stroke. Or sometimes we may say the heart valve is too far damaged and this patient requires either repair of the valve, unlikely, or more than likely replacement of the valve. So this is how, I know I've been jumping around too much because I had about 20-25 minutes. Otherwise I could have dissected this case step by step and taken you through. But this is how I would approach this case as a cardiologist.
I can't tell you how much I appreciate what you just did for these kids. I think that one of the things I learned in my medical training when I was in med school was the importance of an interview and physical exam. And that the physical exam tools, techniques, and confidence often means more than a clinical test. That the expensive tests that you do afterwards are only to confirm what you already know. And everything you just gave these students shows that most of what you came up with, almost all of what you came up with, was by physical exam and interview. The testing that we can do afterwards is just to confirm it. I love that is the message. I really do. In the interest of time, I want to open up for one, maybe two very quick questions, but it's also coming up on 11 o'clock in my part of the world. If the students out there, if you have one or two quick questions for Dr. Iyer, that now is the time, but otherwise we're going to wrap up pretty quick.
I have one quick question. So I know you mentioned that he was a Jehovah's Witness. So how would you deal with the moral issue of this case?
So this question came up last week as well. So it presents a lot of problems for us because anything that you have to do in the cardiovascular system obviously involves the risk of bleeding. And typically, if you tell me that that a patient is a Jehovah's Witness, I usually spend some time with the patient one-on-one because sometimes, the patient themselves, although they are Jehovah's Witness, they'll say, look, if my life is really in danger and if you have to use blood products, that's okay. Sometimes they are not okay. They will tell you, absolutely not. I don't care if my life is in danger, if I'm about to die, you are not going to give me any blood products. So ultimately, if the patient is of sound mind, which he is, then I have to respect the patient's wishes, although I will explain to him what the options are. And the options sometimes we can bank the patient's own blood prior to going for surgery. But there are only so many units that we can use of our own blood. And even some of the Jehovah's Witnesses won't even accept their own blood. So there are various gradations of of acceptability or otherwise. But the good news, for the most part, is the surgical techniques, for instance, have gone to a point where we can do some of these without having to replace blood. But that is typically after the fact. Going into the surgery, I have to be able to have that confidence that in case this patient was one of the unfortunate ones who had a bleeding episode, if I do not have the ability to give him blood, then what could be a routine procedure, say giving 1 or 2 or 3 units of blood, now becomes a major catastrophic problem.
Thanks.
Okay.
I dare say that many of the students on the screen right now would have loved having this lecture about 2 weeks ago, as they were trying to solve the case and we're working through all the clinical aspects of it. But Dr. Iyer, I really appreciate your time. Another tremendous lecture. That's 2 in a row. I just want to have you back every week. So I'm going to set that up. For the students that are out there, I'm going to say goodnight. It's gone a little longer than we intended, but I appreciate your patience. I certainly appreciate Dr. Iyer's patience in going through it. But in the meantime, the video has been recorded. I'll edit it in the morning, get it up onto the YouTube channel for you guys to review if you so choose. But more than that, know that the other talks that have been given by other professionals are also available on the channel. You can look at those anytime once we get them loaded and we're sure that they're available. In the meantime, go back to your classes, go back to your instructors, go back to your classmates, and share what you learned.
Derek,
right.
Thank you very much. It's certainly been a wonderful experience for me. I mean, as you can tell, I enjoy teaching. I do so all around the world. I have been to Jakarta, I have been to Singapore, and the Asia Pacific is not an unknown territory to me, and I really enjoyed it. Thank you for the opportunity for inviting me to do this, and good luck to all of you. And if you have any questions, email Anjali or email me, and I'm happy to respond to your problem. Thank you very much. Have a good night.
Thank you.
Thank you, Dr.
Thank
Iyer.
you.
I appreciate it.
Yeah.
Good night, everybody.
Thanks.
All right.